those who are attending, I'm not sure how many of you, thank you, and I'm not sure how many of you will actually get to see congenital anophthalmos, but it's an interesting thing to know and how we can go about it and refer. So basically, congenital anophthalmos and microphthalmos defects of the globe, which occur basically when there's an abnormality in the development of the primary optic vesicle. So this is basically the embryology, which you don't need to know in detail. But what happens is before the invagination happens, if there is a defect at at a genetic level, then there is no further growth and you get a completely anophthalmic eye. But if there is no defect and it continues to grow at around till about 4 weeks intrauterine, then the defect occurs there. Then what you get is a rudimentary eye giving rise to a microphthalmos. So this is a classical case what looks like an anophthalmos, where you feel there's an absence of a globe, and that is known as true anophthalmos. But if you do a sonography, you'll see a rudimentary or a remnant of an eye, such as is seen in the CT scan of this child. And those are then known as clinical congenital anophthalmos because they present as anophthalmos. There's no real eyeball, but basically you treat it like an anophthalmos. Microphthalmos, you will actually see an eye with basic structures. It may be hypoplastic, and it's often associated with colobomas, orbital cysts. Also, importantly, is you can have bilateral anophthalmos, bilateral anoph with a microph, or bilateral microphthalmos in asymmetrical severity of each eye. So it's important to check both the eyes. So in this patient, he has bilateral microphthalmos, but a more severe in the left eye. This eye looks slightly larger because there's an orbitopalpebral cyst, which we'll come to later. There's a nice classification given by Collins, which he said microphthalmos can be divided into micro-anterior segment and posterior segment. And in this range, there are a gamut of syndromes which occur. And basically, for visual potential, if there is any, it helps us. So when you have an absence of a globe, there is a retardation of cavity growth in the soft tissue. And you can give rise to hemifacial microsomia. That means basically not only the maxilla doesn't develop, the maxillary sinus doesn't develop, and the rest of the face doesn't develop. So you get the findings as was seen in the photographs. You get microblepharon, you have shallow conjunctival fornix, you have a decreased size in the orbital cavity, orbital rim. In a few cases, they form the lacrimal gland is also not developed. So just a quick summary of investigations. A USG is a must. So just do a simple USG if nothing else. And like we discussed, it's more not just to know whether eye exists, but whether any other things such as retinal detachments, colobomas, optic nerve hypoplasia for visual potential. So in this USG, which you can see this is the eyeball, and I've actually taken the study from Dr. Deepak Bhatt. So it says both the eyes. So one is a normal eye, 18.5, but the right-sided is 10.5 with a large orbital cyst of almost 22 millimeters. So in these cases, yes, you do need to do either MRI or CT. MRI gives excellent soft tissue, and it's more for systemic abnormalities involving the brain. But CT is the only thing that will give you an osseous impression of both the rims, so you may need to do one CT. CT is only contraindicated in certain syndromes where you don't want to give radiation. So this I found really nice in this article, which was, even I liked the concept of just breaking it down simply, is that, so if we compare eye and face size, the normal eye at birth is about 70% of adult size, which is great. But the face is actually only 40% of the adult size. And at 2 years, it's 70%. So it's still not really reached its potential. And at 5.5 years, it's about 5.5 years, 9%. Which, just to summarize, which means when you have a pediatrician who's referred the case to you, what you really need to harp on or you're attached to a hospital is that the treatment has to start now. Because you have to work on the orbit between the ages of birth, or 3 months, and 5 years is when you have the potential to expand the orbital cavity. Expansion is obviously done with the goal to increase the soft tissue, which is eyelid and the conjunctival space, and a bony expansion. So this is how I document it every visit. We draw this. The main thing that you really need to do is a horizontal palpable fissure and measure it from medial to lateral canthus. But the recent thing which I've started doing now is that to measure the vertical length, which is a measurement from the sub-brow to the lid margin. So it gives you a vertical phimosis. So also the amount, so the superior fornix is also developing equally. So this recently started doing, as you can see, this is a 2019, it's a recent patient of mine who've been following up for a year and a half. So these measurements we've incorporated now. And this is how we documented very old patient of mine, 2014. You can see here I've written bluish tinge, which will come to, and the entire diagnosis and the plan is made. So treatment can be broadly divided into static and dynamic. Static is things such as acrylic conformers, implants, any cranial adjustments which I'm not going to be talking about, and dynamic such as orbital palpable cysts, which acts as a dynamic thing, which is something that I'm going to talk about, balloon expanders and hydrogel expanders. So principles of treatment are based primarily on axial length if it's a microphthalmos, which means you can take a cutoff of approximately 16 millimeters, so lesser than 16 and more than 16. Second is based on age, like we discussed, based on the facial anatomy. You want to treat between less than 5 years, and now we know why we want to treat them less than 5 years. Above 5 years, your management changes because the bones are not so pliable. And of course, vision. So even in a microphthalmic eye, you will have some potential of vision. So if the visual, so how do we test that? So the pediatric ophthalmologist will either check with charts or VP, and also fundus dilatation if you can do it. So based on this, it's broadly classified into less than 16 millimeters with or without visual potential, and more than 16 millimeters with or without visual potential. For anophthalmos, you have to treat it any which way because there's no eye potential. So if it is less than 16 millimeters and there is a visual potential, then you want to give a little bit of a transparent acrylic conformer. You don't want something opaque because you still want light stimulus with the potential that you can develop the eye later. But there is no visual stimulus, then you can consider other things which will be coming to. What they've said in some of the other things also is that even the hydrogel expanders and all, because they're translucent, you may have some amount of light. But if the person has a better potential than that, then you want to reconsider those, though they are some things that have been recently being used, which will come to case by case. So simple acrylic conformers, which in fact I still do, is a microphthalmic eye, other eye is normal. Start with simple conformers where you have to measure it with your ocularist, get it sized as small as, sometimes you're starting as small as 6, 8 and going. So I change them every 4 to 6 weeks. They go to the ocularist, change it, then come to me and I do the measurements. So at every 4 to 6 weeks, we continue to change. Pressure conformers for very, very small eye sockets, because sometimes the small conformers don't stay. So this little stick comes out and you can put a micropore and keep it. And something which is more recent, which I heard Dr. Hanau talk, was AIOC prosthesis or AIOC conformers, which are conical shaped, so they give a little pressure and allow the orbit to grow. We have not tried them so far with my ocularis. Now, orbitopalpable cyst, this patient's eyeball is deviated downwards because they have massive cyst here. So this is the eyeball and this is the cyst. So ideally, this stimulates orbital growth. So you should leave it alone. And the child here who's come to us is 4 months. I would have mostly left it alone, and we did leave it alone till the ages of 7 to 8 months. So it acts as a form of dynamic expansion. But the cases when you're going to remove it is when there's a rapid growth, it's not allowing you to place a conformer. Suppose the age of the child is and the cyst is disproportionate, you want to consider removal, and the volume of the affected orbit. So if the orbit is looking bigger, then it's causing an expansion which you don't want. So you want to have to treat it. Treatment is aspiration with sclerotherapy or excision. Now, word of caution for excision is that you don't want to try and do too many surgeries because you don't want scarring in the conjunctiva, which will again give you contracture. So aspiration, sclerotherapy, tried and tested. Yes, have to do an MRI to see there is no connection with the eye or the brain before you go in and stick a needle and aspirate it. So this is a girl 2 months old who came to us with an orbitopalpable cyst. Classically, you will see a lovely bluish tinge swelling here. Sometimes you'll have an entropion. You can see the orbital cavity is expanded significantly. So at 2 months, we did an aspiration. That's the cyst. And that's after the aspiration. Immediately put a conformer and do a tarsography. So this is a little snug, but you want it to be a snug fit. You don't want a loose conformer spinning. Then coming to recent concepts. Now the reason recent concepts have come about is we're constantly taking the child in and out or sending them an ocularist. So the whole concept was, let's not do that. And this was one of the first ones, so I've tried to do it chronologically, which is in 1999, Weiss came out with this concept of hydrogel conformers, which are made of, so our contact lenses are made of PMMA, this is MMMA, methyl acrylate, and pyrrolidone. So this combination comes in 2 forms, a socket expander and an orbital expander. And there's a nice thing which tells you the size of what you get it to what it expand based on just tears and tissue secretions. Now, what they felt is once you've taken this, so you expand the socket first, which allows enlargement of fornix and the eyelids, and then you have orbital expanders, which are done after about a year, where then you have to actually do a surgery and put it into the orbit. And they've had very good results. There are a lot of papers published. This is one of the more recent ones I've put up, which is published. So this is a socket expansion, which is done. Then an orbital expansion. So socket expansion, prosthesis, orbital expansion, okay? And then you can do orbital implant exchange. Now, we haven't tried any of these, but during our fellowship at LV Prasad, Dr. Seema had done a project, and what we found is for the orbital expansions, they were, they were inflating really well. But the thing is, a lot of times they had extrusions. Now, recently they've come with better techniques of how you can go, but the primary complaint still to be extrusion. That is not to say that you can't do it, but you can consider. Now, what I have tried, or what we are just about to try in 2 cases upcoming, is doing a socket expansion, which is in place of an acrylic conformer, we put the hydrogel expander in the socket. And Dr. Katya Tambe from UK said that what they do is for socket expansion is they don't even use tarsorrhaphy. They put it, so basically to go back, they put this hemispheric ring in the over the conjunctiva and take a suture tarsorrhaphy. Some of them have now stopped doing suture tarsorrhaphy and do glue tarsorrhaphy with cyanoacrylate glue. So it stays for about 15-20 days. It wears up in 2-3 days, and then they change it and see if they need to put another one. Now, this works there because the insurance covers it. Here, cost also becomes a factor. But so we've got a donor, and we are trying to do 1 case to see at least not if orbit, because it's a microphthalmic eye, which does not have much visual potential. We're going to try and see if it works for the socket. Just take half a second. Now, this is another recent concept. So 2019-19 one was the hydrogel, and then our papers have been published. And this was in 2007 at Bascom Palmer by David C. and Perel, who's a scientist, who basically came up with the concept of, again, they're saying you're doing surgery, you're removing, taking out, removing, taking out. So what here they're saying is, this is basically something which looks like this. It's like mounted on a plate. It's a silicone inflatable ball, which you make a periostal incision, go through the lid, put it behind the conjunctiva, stays on the orbital rim, and this little thing stays open, and you inflate saline up to about 5 cc's, and that's what gives it the orbital, and over that you put a prosthesis or a conformer. So here what they're saying, it negates the process of repeated surgeries. So this was done in 2007 on cat models and showed an excellent results, and then they published in 2011 with 9 patients. Now they've all said very good, and Dr. Tarjani from LVP did 1 because they tied up with them. So 2 things she found was that beyond a certain point they couldn't inflate it, and second, I think cost again was a factor. So this is another thing, and I remember when I had gone, I was there when they had done this in 2007, and Dr. C told me at that time, even there, it was working out to Indian rupees of about 60 to 70,000. So you can do a cataract in 60 to 70,000, but most parents are not willing to spend that much for this. So implant surgery is, I'm going to just skip to that. So to plan management early, so this is a child who came at 2 months, and this is exactly at a year with just serial conformers and then final prosthesis, and we've achieved the size. So have to examine the other eye, individualize the treatment plan, and please counsel and support the parents. So we have only about 10 patients, but my oldest patients who started with me, and the kids are a little older, have now become my counselors for the other patients. So thank you.